Hello, thank you so much for joining with me today. So, you are a mathematician, right? And
Yes.
we even published an article called about bias in networks, right, in public health.
Yeah, so I'm a mathematician by training, and my current focus is on critical decision making, and in particular on quantifying uncertainty using causal probabilistic models. These are the Bayesian networks, and the idea is they combine data and knowledge, and we call that a smart data approach, in contrast to the sort of the big data fad. Since the COVID crisis began last March, we've been applying these kinds of techniques, which are kind of a contrast to the mainly sort of machine learning or just simple number crunching statistical methods that most people have applied in this area.
Yes, that's the first questions I will make you. What have you to say about basically Neil Ferguson's models and the whole models that are consistently explaining these restrictions?
The thing is, those models, they were in many respects a major driver of the government's draconian interventions because they grossly inflated predictions of deaths without lockdowns, and they were not based on really any empirical support for the efficacy of lockdowns. And the interesting thing where we've got a challenge is that people who are skeptical of the sort of the official media and government narrative on COVID are therefore also kind of like rightly skeptical of mathematical models in general. So that creates a little bit of a problem for us. But as I say, where we differ is that we don't simply do predictions based on basically the number crunching of the data that's available. We look at causal explanations for the data. We look at biases, uncertainty about its accuracy, and also key information that's missing. So we build these causal models using knowledge as well as data, and we use these novel statistical methods, these Bayesian methods, to produce assessments which we believe are more accurate and informative and take full account of all these factors. So maybe as a simple example, if you want me to carry on, right at the start of the crisis in March 2020, it was widely reported and accepted that similar neighboring countries in Europe had very different infection and fatality rates. And it was automatically assumed that those differences were due to things like when the infection first struck, when and if lockdowns began, demographic factors, and healthcare quality. But it turned out that the major explanation for the differences at that time was simply the different ways that countries classified what constituted a COVID case and a death. So in the UK, for example, at that time, the only people that were being tested for COVID were patients already hospitalised with severe symptoms. And that meant that the fatality rates for people with COVID were grossly overestimated. And international comparisons were meaningless without understanding the differences in national testing strategies and national death reporting strategies. So at the heart of it is what constitutes a COVID case.
Okay, so what is the major mistake in these models that the government are being used to? What is the major mistake?
I'd like to focus on the major mistake in the whole of the ongoing narrative and the whole of the narrative, for the continued support of lockdowns. And it's all because it's driven by this idea, the count of a case, where a case is not what most people assume a case is. It's a total break with previous medical orthodoxy, where a virus cases required a person being diagnosed with particular symptoms and illness. Here we have a person defined as a case if they test positive with a PCR test, even if they do not or would not have any symptoms. Now, look, a lot has been said about the unreliability of the PCR test and how it's been used routinely at cycle thresholds, beyond the intended limit to exaggerate the number of cases. So obviously, if you change any of those things, you can change the count of number of cases and you can spin your narrative, how you like it. But the problem is especially acute when it's used, as became increasingly widespread in the UK since last summer, being used increasingly on asymptomatic people, i.e. we're testing people who don't have any symptoms, enormous amount of testing, and declaring that they're positive, they test positive on a PCR test. And that's where our mathematical approach, the Bayesian approach, exposes the scale of the problem. I mean, I don't know if you want me to talk about...
Yes, please, I want to talk about it. What the Bayes term applied PCR, what is the problem with the PCR test? And
so,
mass testing, in fact, mass testing.
Yeah, so first of all, the problem is that when you're using it at these very high cycle thresholds, you're not really detecting people who actually have any potentially infectious virus. So a lot of the positive results are false positives, right? Let me explain. So let's suppose...
I'm sorry. Just to start, you are right. Yeah. But what is a false positive? What it means?
Okay, sorry. So a false positive is somebody who does not have the virus, but tests positive with a PCR test. So the test says this person has the virus when they don't really have the virus.
Okay.
Right? And that can come about in many different ways. There can be errors in the labs. There can be problems in the way they deal with the reagents. It can be that they're not sticking to the procedures of how many genes that they're testing on, and too many. The cycle threshold is too high. So it's known that there'll be a small number of false positives, right? It doesn't matter the exact numbers because there's some debate. Some people say it's only 0.25%. Some people say it's as much as 2%. But let's just suppose, for purposes just to illustrate the problem, let's suppose there's a 1 in 100 chance of a false positive. That means that 1 in 100 people who doesn't have the virus will test positive. That's what it means. So if you look at 100 people who don't have the virus, they definitely don't have the virus, one of those will test positive, will be a false positive. That's what a 1% false positive rate means. Now, let's suppose that somebody tests positive. What is the probability that they actually have the virus? Well, most people think, it's only it's 99% chance they're positive because there's only a 1% chance of a false positive. Well, no, this is the classic mistake, okay? Because you can only answer the question, what's the probability that person has the virus, if you take account of the underlying true infection rate. So let's suppose that for asymptomatic people, the true underlying infection rate is 1 in 1,000. So we know that out of every 1,000 people who are asymptomatic, only 1 has the virus.
Okay.
Now imagine that you randomly test 10,000 asymptomatic people. Then what we know is that because of that 1 in 1,000 infection rate, we know that about 10 of those really has the virus. So about 10 out of the 10,000. Now that leaves just under 10,000, 9,990 or whatever, right, who don't have the virus. So that's still nearly 10, it's just under 10,000 people who don't have the virus. Now, if we've got a 1 in 100 false positive rate, that means that 1%, which is basically about 100 of those almost 10,000 people, will test positive, and they're false positives. Those people don't have the virus, but they're testing positive. So let's assume that the 10 who do have the virus generally test positive, but we've now add to that 100 who don't have the virus and also test positive. So in total, what we've got is 110 people out of that 10,000 who test positive, but only 10 of them have the virus. So actually, only 10 out of 110, which is less than 10% who test positive, have the virus. So in fact, what that means is that if you test positive, there's a less than 10% chance you've actually got the virus, even though the false positive rate was only 1 of 100. And that's the thing that most people don't really understand.
Yes, and create the illusion that are many people with the disease.
Exactly, and so most of these asymptomatic people who are testing positive, they really are just false positives. So you've got this massive exaggeration of cases because of these asymptomatic false positives. But also, incidentally, even people with symptoms, there's certainly false positives amongst those people because the symptoms that they're using are, of course, common to so many other, to any other cold or,
Yeah,
So
you are
yeah.
telling me that even a sick person can have a false positive
Absolutely.
and
Right.
be
So
sick with another thing else?
in fact, just think about it. Anybody with a cold
Yeah.
is going to have symptoms which are same as COVID. And they then, if they test positive, just as we said with asymptomatic people, in fact, it's even more likely with them that they'll be incorrectly, that will be a false positive. You know, we've had millions of asymptomatic people tested since last summer, and and many of these were false positives. The other thing about that, where you get this misconception, is this idea that the government in the UK, I'm not quite sure what it's like in the rest of Europe, you may have heard this, right? They have incessantly been pushing this mass media message that 1 in 3 people who have the virus have no symptoms and could be spreading it without knowing. We've done a lot of work in exposing this, right? Now,
Yes.
I'm not clinically trained, so I'll ignore the medical arguments which suggest that the asymptomatic spread of a virus isn't really a thing. So even if you ignore that medical stuff, but just focus on the claim from a mathematical perspective, we were able to prove that that claim is wrong. And the reason it's wrong is because when they say that 1 in 3 people with the virus have no symptoms, what the data really suggests is that 1 in 3 people who test positive have no symptoms. So in actual fact, it's currently we believe it's a much higher proportion. Again, they're equating testing positive with having the virus. And in fact, what we were able to do was we used data from a very extensive study of testing asymptomatics in Cambridge. And
yes, I saw this study.
yeah, what was special about that study was that it gave us real insights into the extent of false positives among asymptomatics. Because what they did was that for each positive test, they retested for confirmation. Yeah. And so in the period of the study, there were 43 positives, but only 7 of those were confirmed as positive when they were retested. So 36 out of the 43, i.e. most of them, 84%, were false positives, which is kind of like similar to what I was explaining, using those sort of kind of like hypothetical figures. So those hypothetical figures I were given were very close to what we saw happen in practice. And by extrapolating the results to the government's data for the whole of Cambridge, we showed that the 1 in 3 claim, when you focus, really, if you're talking about 1 in 3 people with the virus have no symptoms, if that was true, then their estimated real infection rate was over 10 times what the true infection rate was. And conversely, if you accept the government's estimates of the infection rates, then only 1 in 34 people with the virus have no symptoms and not 1 in 3 as claimed. So something's wrong. That 1 in 3 claim isn't consistent if you accept it as a genuine claim about people with the virus as opposed to people testing positive. It's inconsistent with the claims about the number of people who are really infected. So everything's exaggerated. So the number of people, the claims about the number of people infected with this virus have been exaggerated.
So what do you think is the real prevalence? I don't know if the right word, prevalence of the disease right now.
It's been changing all the time. I mean, when we did an extensive study of the publicly available data that was available last summer, we were agreeing with the kind of thing that John Ioannidis at Stanford. Yes. We were looking at those sort of, I can't remember exactly now, but I'll be perfectly honest now and tell you that I made a decision in December of last year. We'd done a lot of modeling using the published case data. We made a decision that because we were so completely distrustful of what a case meant, and therefore what a death meant, what a hospitalization meant, because it was all based on that fundamentally flawed definition of a case equal to a PCR positive test, that I no longer believe, I actually stopped doing any analysis that was based on case data. Yeah. I think it's all completely useless. And any published data estimating infection rates, which is based on that data, is simply worthless. I wouldn't even bother to give any estimates anymore if it's based on that. Simple as that. It's completely worthless.
Yes. Another question. I saw in your Twitter last month in May, you did a response to the Lancet, because the study in Israel about the 25% efficacy on about the Pfizer vaccine.
Yeah.
Can you explain to us what your response say, and if you already have any answer?
I had a kind of an answer. They said that they had to put the responses to the authors to give them time to make their own response. Well, that's now been, I mean, that's ridiculous, because the article went out on May the 5th and the authors should have had a chance, I would have thought, to respond by now. So we still haven't heard anything, despite them saying that we would hear. But our concern there was that because it wasn't a randomized controlled trial, so they knew who were the vaccinated and who were the unvaccinated. It wasn't like a blind experiment. And what happened was that the vaccinated people no longer had to do the routine PCR testing, which the unvaccinated people did. And so you've already got a situation where if you're trying to evaluate effectiveness on how many of the people after vaccination compared with how many people who weren't vaccinated actually get the virus, and if you're basing that on PCR testing, then the fact that you're simply doing much more PCR testing on the unvaccinated compared with the vaccinated introduces a massive bias in your results, which you have to account for, and they never did. And we did a simple, almost back of the envelope calculation based on factoring in the amount of testing that was done, because it wasn't equal for vaccinated and unvaccinated. On the basis of that alone, the effectiveness came down from about their claim 95% to about 75%. But I would take all of that with a pinch of salt, even what we did, because other people have said they didn't account for other things as well in the way they did it. But I would take it with a pinch of salt anyway, because what all these studies haven't really done is looked at the trade-off between cost and benefit. It's one thing to look at how much the incidence of COVID is reduced in the vaccinated compared with the unvaccinated. That's one thing. And of course, that's already massively compromised by the fact that it's dependent on the PCR test, which is inaccurate, right? We've got all that problem. But sure, the most important test of effectiveness is that people don't die or don't have serious adverse reactions. And there should be enough data to simply compare similar people with the vax and without the vax. And that's not really being done at the moment in terms of, we know that people have raised concerns about the serious adverse reactions and the amount of those compared to other vaccines in the past. But that's the data that needs to be focused on. That's where we should be looking at the comparison between vaccinated and unvaccinated. And that really hasn't been done. That's being completely avoided. I mean, hopefully in the next few months, we're going to be getting access to data which looks at that. And that's where you cut through. You can cut through you don't need to rely on PCR tests now, because we're simply going to look at the number of people dying or having serious, heart problems, lung, whatever problems, completely, and not even consider this issue. The issue of whether or not they have COVID is irrelevant there. You're simply looking at what happens to these people, because if COVID is as serious a problem as is being claimed, if it's killing as many people as being claimed, and if the vaccination is as effective as is being claimed, then we should see at the end of that period that the number of deaths, within particular age categories, that the number of deaths of people within the same age category in the vaccinated group should be less than in the unvaccinated group.
Yes.
That's what we should be seeing. It's as simple as that. Any measure other than that is not worth thinking about.
So you wrote an article about the COVID protocols, criticizing just that the protocols will make a bias, and we simply will not could understand the efficacy of the vaccination, right? Because they only test the unvaccinated people. That is the problem.
Yeah, there's a completely different testing protocol for the unvaccinated and the vaccinated in Israel. So for example, those who are unvaccinated got on average 2 PCR tests each, whereas the vaccinated people effectively they weren't really being tested at all. Only on average about 1 in every 20 or something was tested in the whole period. So you've got these completely different testing strategies. So obviously, I mean, it can work both ways, but the point is that given the false positive rate for asymptomatics, so the people who are being tested more, more likely going to show up as being COVID positive.
Yes, yes. So, what you really think? What you think that it is the real efficacy of the vaccine? Do you have any idea right now?
I think that it may well be leading to reduced numbers of PCR positives. It may well be. We don't know because we don't really know how they're doing that testing, and we don't know whether they change the cycle threshold when they're doing it in a study compared with for the population as a whole. We don't know. All of this stuff seems to be a little bit vague. Even in the randomized controlled trials, there's some, there seem to be some doubts about that. I think from what I've seen, it could well reduce the number of PCR positive tests amongst those who are vaccinated. But at the end of the day, that's meaningless without looking at the impact on serious illness and death. That's why that's the only thing that ultimately matters. Does it stop people actually dying?
Okay, one last question. So you belongs to Hearts, that is non-profit organizations who was speaking somehow against the COVID narrative. Here in Portugal, we simply don't have nobody to speak against the narrative. And here in UK, I have seen some censorship to some people. How are the things here? They are better, they are worse, that they are more open to discussion.
Look, people say, well, there isn't censorship because you guys are able to express your views on Twitter and stuff like this.
Yes, so, but then Twitter deleted.
Exactly. So this is the whole thing. We actually have to be incredibly careful. We've had stuff censored. We are massively censored, right? We are. I mean, look, people write to Queen Mary, demanding that I be sacked for sort of expressing these opinions which are contrary to, to the sort of official narrative. I've been fairly careful about what I've said, but the censorship, it's enormous here. There is. On the mainstream media, the BBC, Sky News, there isn't any alternative. These alternative opinions simply aren't presented. People simply don't know about them unless they're plugged into particular niche websites or social media accounts. There are some websites. There's a Lockdown Skeptics website here that raises these issues. There's Heart, but we're classified as nutcase conspiracy theorists. That's yes. That's how we're classified. And yet, when you think about it, amazing reason why the narrative continues and why, politicians and a lot of academics, this is the thing, it's not just politicians, it's a lot of academics
yes.
who are pushing the official narrative. And the point is that those people who are pushing for this, it's the ultimate sort of risk-averse thing. We've got every life we can save. It's the single focus on COVID deaths and nothing else, right? But the people then who are pushing that, they're completely unaffected by the negative consequences of lockdowns. Those people have no skin in the game. I mean, if in contrast to sort of the independent workers and small business owners who lose their whole livelihoods with lockdowns, not a single politician or academic will lose a single day's work or pay. I mean, in fact, for many of these people, their lives have actually been made easier by being able to work from home because they're basically a privileged elite with typically with large homes and gardens. They're simply not affected by it. The other important thing is that there are these other underlying narratives. There is no doubt that this whole lockdown narrative, the whole restrictions, on travel, etc., it fits in very well with the sort of the climate change narrative. And I realized very early on that a lot of academics were supportive of lockdowns, not because of the science to support them, or even the science on which the basis for the claims about the seriousness of COVID were made, but simply because it fitted in very well with this idea of we've got to reduce carbon emissions, we've got to stop international travel, stop car travel.
saving the planet. So
they're very happy. In fact, now it's in the open. Many are openly saying that this is the necessary precursor for, for climate lockdowns. And there you see, this is why this narrative is being compounded.
okay, yes. So we continue to fighting against the narrative. So
Yeah.
thank you so much for answering me some questions, and we keep trying to pass the message. Okay.
Yeah. Okay.
So,
Nice to speak with you.
bye.
Okay. Bye.